Hello, my name is Atul Verma from Montreal, Canada, and I'm very pleased to be hosting this session on EHRA Studio. I'm here with two great friends, Misha Kühne from Basel, Switzerland, and also Helmut Puererfellner from Vienna, Austria, who also happens to be the president of EHRA. And Misha was the lead author of a very important document, I think, which was the EHRA PFA scientific document. As you know, PFA has really taken our world by storm, and so EHRA felt that it was very, very important that a document be put out. So maybe, Misha, you can talk a little bit about the structure of the document and what people can expect when they read it.
Yeah, thank you very much, Atul. I think people will find the document a great resource to read up on PFA. We, as a scientific writing committee from EHRA of the ESC, we heard a lot about PFA in the last few years, about it being a disruptive technology, being a breakthrough technology. But I think as an EP community, we like to know the facts and we like to know and see the evidence. So as a scientific writing committee, we thought it would be appropriate to put together a document about all the evidence, so the clinical evidence that is currently available, but also the workflows on how procedure-wise PFA is performed, on the biophysics, but also about teaching and education for pulse field ablation performing the procedure.
Yeah, I think that's so important because, of course, we've had this explosion in the technology with a lot of excitement, a lot of advertising, and a lot of money. But at the end of the day, we're clinicians, we're scientists, and I think putting all of it into context was really, really important. So what would you say are the highlights from, let's say, a workflow point of view? Do you talk about different types of sedation? Do you talk about the different types of technologies, how to use them?
Yeah, definitely. Great question. I think in the document, we try to come up with the standardized terminology on, for example, deep sedation, conscious sedation, general anesthesia, when and how to use it, but also in terms of stuff like entrance and exit block as clinical endpoints for the procedure, anticoagulation workflows. So the document really provides a step-by-step, sort of simple cookbook type guidance to how to perform PFA ablation, but staying open to different kinds of workflows. Let's say fluoroscopy only versus using mapping systems, or including ICE or not including ICE. And I think there are many different ways to perform PFA, and the document honors this.
And obviously there's a huge amount of evidence out there about the safety and the efficacy of PFA. But of course, we've come to realize that there are some novel issues with PFA that we weren't expecting. Does your document go into that and try and explain and clarify those issues for the readers?
So that's, again, a great question, because it's very new evidence that we're just now generating, and we're learning more about PFA. I think the first point that you're alluding to is probably the vasospasms that we sometimes see, and that has been seen mainly when PFA is applied in the vicinity of coronary arteries. For example, when it is performed on the cavo-tricuspid isthmus. And this has been shown that applying nitroglycerin, initially intracoronary, but now also just IV nitroglycerin, is very potent in being a prophylaxis for these vasospasms. So this is covered in the document. The second point that you're alluding to is probably the arrhythmias that have recently been reported.
Yes.
And they occur in different settings. They've mainly probably occurred with ablation in the ventricle. And it is, at this point, I think, not clear what the exact mechanism is that PFA can induce these malignant ventricular arrhythmias. This is certainly something to be looked at further in the future, and it is mentioned in the document what are gaps in evidence that need to be looked at further in terms of safety as well.
Fantastic. And maybe, Helmut, I'll turn to you for a moment. One of the other very important parts of this document is trying to understand the skill set, the training, the certification for being able to do PFA procedures. Do you perhaps want to highlight some of the principles that were outlined in this document and why you think it's so important to have this section in the document?
Thanks, a very, very relevant point. We thought about what is also a duty of a society, arrhythmia society like EHRA, in this context, in a field that is rapidly growing. And of course we thought, what is the training you need? What is the amount of procedures you should do on a routine basis before you get skilled? What is the level of experience you should have before you start? What is the transeptal puncture? What is the ultrasonic guided puncture in the groin? This is all very relevant, and it's very relevant because we are now dealing with catheters that have larger sheaths, 12, 13 French. So if you have a puncture in the groin with a complication under heparin, that might be a disaster. So it's very, very relevant that you are trained in ultrasound-guided puncture, which was not the case when we did RF because the catheters were smaller in that way. And so this is one of the things that we want to promote even further. And then, of course, this large sheath, the flushing of the sheath, the air that we have to get out. So these are the things that we recommend practically. But then we also make a statement, you need to do it regularly in order to get an expertise on this. And we also want to structure it in a way that it's a procedure. You need to be trained and then also examined, certified for this procedure. You have to have skills and knowledge for this procedure, and it's not just that PFA is so simple and it's so effective and there is no side effect and everybody can do it. We wanted to really kind of frame the whole thing around certification, examination, training, in order to make it, you know, a safe and efficient procedure. And that's very relevant as for us as a society, as I said.
You know, it's interesting, Helmut, because, you know, the tools that we're being given, and, you know, many of the procedures are not even being done with mapping anymore. The signals go away almost immediately. So you could argue this is just a cookbook, right? We can just apply X number in each vein, you know, snap our fingers and we're done.
Yeah.
So what about mapping signals, that skill set that electrophysiologists bring to the table as opposed to anyone else who might try this procedure?
It's still there. It's still electrophysiology, what we deal. And it's not only atrial fibrillation. We have atrial tachycardias. We might have other arrhythmias linked to it. And then, of course, in the future, we will have ventricular arrhythmias that we will also treat with PFA. So we will have all the skills that we need for electrophysiologic procedures. We also will have to look at the signals at least before we go in with PFA. The problem in PFA is that you get rid of the signal very early. But I think we need electrophysiologic understanding And then, of course, when we have redos, we will have atrial tachycardias. We will have to look for gaps. We have to define the tachycardia circuits, the critical circuits. That is all electrophysiology. That's not just learning by burning, as we said in the times of RF.
I couldn't agree with you more. I mean, I think there's still so much to be learned about the mechanisms of atrial fibrillation, how best to tackle ventricular tachycardia and ischemic and non-ischemic substrates.
And maybe I might add, we also wanted to say, you have instructions for use because all the systems are their own systems. We don't have a class effect. And don't go over it because you think it's safe. Don't go for example, I go for that. Don't go for posterior wall if there is no reason. If there is no reason, no scar, no tachycardia circuit, don't go for that. There is no evidence. And only because PFA is here, there's no reason to do that. Not at all. So that's what we wanted also to give as a message.
And you know, I was involved in writing a similar document for the EHRS, which EHRA co-sponsored as well. EHRA obviously has come out with this very important document. From a societal presidential point of view, Helmut, you know, why another document, and why specifically a European document?
Yeah, that's what we were asked for, and I think we have good reasons for doing that, because we are very different from, for example, the United States, where the EHRS document comes. Our healthcare systems are very different. The way we do our sedation protocols in the United States, at the moment, at least 97, 98%, as I've seen today in the morning, are done with GA. In Europe, 10, 20%, something like that. In some selected patients with problems with where they're having problems with the lung or are very obese. So we have very different workflows, very different healthcare systems where we work. And so we thought this is necessary now to also to do it for Europe, because we were living in different environments. And even in your country, you're even closer to us than to the United States with regard to the healthcare system. So I think that's a very important point, and that's why we think it's appropriate to do two documents. However, we already discussed together that we will have an executive summary. It was your proposition to do that, Atul. It's a very good idea to do an executive summary, what we have in common. And that will also be teaching, certification, things like we talked about for all the whole globe.
It makes complete sense. And so maybe, Misha, I'll give you the last word on this. You know, we have so much evidence. We have so many trials out there. We have different messages about safety, complications. Obviously, PFA is here to stay. But are there any sort of helpful words of advice, having chaired this document, pulled together, you know, so many different opinions that you can give to the viewers out there who are going to be looking at this document?
I think we've definitely already, with this relatively still young technology, come a long way. And I think we have really well-established workflows for PVI only, especially in patients with paroxysmal AF. But when we look at persistent and long-standing persistent AF, also other arrhythmias such as ventricular tachycardia, also redo procedures in patients with AF, I still think we need more trials and more evidence for the future to be able to also treat these patients with the same kind of safety profile and the same confidence as we're doing paroxysmal AF PVI only procedures at the moment.
Fantastic. Well, I would like to thank all of you for your attention to this broadcast. I would really like to thank Misha and Helmut for joining me and having this great discussion. And I would really encourage you all to download the EHRA scientific document on pulse field ablation and gather the knowledge that's inside this wonderful document.